Welcome. Today, we're doing something a little different. We're stepping right into the pressure cooker of a consultant-level surgical exam. I'm going to play both roles here, the tough examiner and the sharp candidate, to walk you through a classic case of liver cancer. Let's get started.
In a viva exam, structure is absolutely everything. So we'll move logically through the case. From presentation to the workup, staging, the management plan, we'll even throw in a critical complication. And then we'll wrap up with the key takeaways. This kind of framework, it's your path to a clear, confident answer.
All right, I'm putting on my examiner's hat now. So just imagine you're in the hot seat. Your whole career has been leading up to this moment. You take a deep breath, and the exam kicks off with the opening scenario.
Good morning, let's begin. A 65-year-old with known cirrhosis from hepatitis C is referred to you. A screening ultrasound shows a 4-centimeter lesion in the right lobe of the liver. How would you proceed?
Thank you. I would approach this systematically, starting with the full assessment of both the patient and the lesion itself, just to make sure I understand the complete clinical picture.
Very well. Outline your initial approach and tell me what key diagnostic findings are you anticipating on the imaging.
My initial approach breaks down into 4 steps. First, a really comprehensive history and physical exam, where I'm specifically looking for any signs of decompensated liver disease. Second, I'll need some laboratory investigations. Liver function tests, a coagulation profile, and of course the tumor marker alpha-fetoprotein. Third, we need definitive diagnostic imaging. And finally, with all that information, I'd formulate a differential diagnosis. But let's be honest, with a background of cirrhosis, hepatocellular carcinoma, or HCC, is right at the top of my list.
So for the imaging, my go-to would be a multiphasic CT or an MRI. Now, the classic radiological signs for HCC are really driven by its unique blood supply. What you see is this intense, homogeneous enhancement in the early arterial phase, which is then followed by a washout of contrast in the later portovenous phase. These features are actually so specific that in a patient with cirrhosis, you generally don't even need a biopsy to confirm the diagnosis.
So with a diagnosis looking very likely, we're ready to move into the next phase, the full workup and staging.
Correct. The MRI shows features typical of HCC. So now we have a diagnosis, but we don't have a plan. How do you formally assess the patient and the disease from this point on?
My assessment now has 4 absolutely essential components. 1, I have to formally assess the degree of the underlying liver disease using the Child-Pugh and MELD scores. This tells me what the patient can actually tolerate. 2, I would stage the tumor to check for any spread. 3, and this is crucial if we're thinking about surgery, I must measure the future liver remnant, the FLR. And 4, I'd put all this data together to determine if the patient is a candidate for resection or even transplantation.
The Child-Pugh score is such a critical clinical snapshot of the liver's functional reserve. It's not just a number. It really determines if the patient can survive a major operation. Using these 5 parameters, a score of 5 to 6 puts you in Class A, which means well-compensated cirrhosis. For our patient, let's assume they have no signs of decompensation, which would make them a Child-Pugh Class A.
Next, I'd look at transplant eligibility. This has really strict criteria to make sure we get the best outcomes. The classic Milan criteria, for example, allow for a single tumor up to 5 centimeters or up to 3 tumors as long as each one is no larger than 3 centimeters. The USCF criteria are a little more expanded. Our patient, with a single 4-centimeter lesion, fits comfortably within both of those.
Okay, let's get to the definitive plan.
Excellent. So, for your Child-Pugh A patient with a single 4-centimeter lesion and an adequate future liver remnant, what is the standard of care, and what are its non-negotiable surgical principles?
For this patient, the standard of care is surgical resection with curative intent. There's no question. And the key principles are, it has to be an anatomical resection that respects the segmental anatomy of the liver. The goal is a 1-centimeter cancer-free margin, and critically, we must preserve an adequate future liver remnant with its blood inflow, outflow, and biliary drainage all fully intact.
Good. Now, what if the patient was a Child-Pugh B, making them ineligible for resection? What are your options then?
Well, if the patient is not a resection candidate because of poor liver function, the gold standard becomes liver transplantation, since they meet the criteria. For smaller tumors, thermal ablation can actually be curative. For larger, unresectable disease, we can use therapies like transarterial chemoembolization, or TACE, to control the tumor, and that often serves as a bridge to a future transplant.
A good candidate can handle the standard case. A great candidate, though, can handle a crisis. So,
Before you can proceed with definitive treatment, your patient shows up in the emergency room vomiting large amounts of blood. What is your immediate concern and how do you manage this?
Okay, my immediate concern is a life-threatening upper GI bleed, almost certainly from esophageal varices, caused by their portal hypertension. The management has to be immediate and protocol-driven. First, get them to the ICU and start careful resuscitation, targeting a hemoglobin of 7 to 8, because over-resuscitating can actually make the bleeding worse by raising portal pressure. Second, I'm starting medical therapy, octreotide, prophylactic antibiotics, and a PPI. Third, arrange for an urgent endoscopy to get those varices banded. And if the bleeding still persists, a TIPS procedure would be the next step.
All right, now for the summary. This is where you really secure the pass.
So to summarize the key high-yield points you have to know. First, screen all high-risk cirrhotic patients with an ultrasound every 6 months. You have to catch these lesions early. Second, when you resect an HCC, a 1 centimeter margin is the standard. Third, resection is strictly for child A patients. And finally, for any child B or C patients with tumors that are within Minzy criteria, liver transplant is the definitive gold standard treatment.
And just as important are the common pitfalls. The critical errors to avoid are forgetting to formally calculate the future liver remnant before a major resection, offering resection to a child B or C patient who simply will not survive it, over-resuscitating a variceal bleed, and attempting thermal ablation on tumors that are too large or too close to major vessels where it's just ineffective and dangerous. One final question. You have successfully resected the tumor. The patient is recovering well. What do you tell them is now the single biggest threat to their long-term survival? And the answer isn't just cancer recurrence. It's the underlying progressive cirrhosis that's still there. This really just brilliantly illustrates the core challenge of managing HCC. You're not just treating a tumor, you're managing a failing organ.